Welcome to the Demonstrating Implementation Excellence stream of the SNOMED CT Expo 2021. My name is Kelly Carew. I'm the Chief Communications Officer at SNOMED International, and I'm very pleased to be introducing today's session. As a note, please use the lock in your AirTouch device to type your questions to the presenters. All questions will be answered at the conclusion of the presentation. And I'm now very pleased to introduce Dr. Ismat Mohd Sulaiman, who will be presenting SNOMED CT as features to predict the danger of medical abbreviations. Ismat, please proceed.
Thanks, Kelly, for allowing me to share this session with everybody. So I'm Ismat, and I'll be presenting to you on my little research project on the danger of medical abbreviations. Right, let's get on. So as usual, we'll be talking about the four aspects of the research. And as an introduction, I just want to let everybody know, and I think everybody is aware, but just to highlight the numbers, that actually medical abbreviations are not only common, but they are ambiguous. So what that means is when you say something is ambiguous, it means that one abbreviation can have two or more meanings. So imagine if you had to refer a patient and you write in your clinical notes, whether electronic or manual, you write an abbreviation and you want to refer to another discipline, but the other discipline has another meaning to your abbreviation. Or in another example, whether it's in the same institution or even in a different institution, like for example, if you want to refer your patient to a downstream to a primary care, or from a primary care to a specialized hospital. So my research is a little bit about that. It's about terminology, and I'm trying to gauge on how SNOMED CT can play a part in helping how to disambiguate these medical abbreviations. But before we get to that, there are previous studies before that uses electronic health record that studies abbreviations in these electronic medical records. One is by Holper et al. They found that 8.9% of their medicine clinical notes the words are abbreviations, and 1/3 of those abbreviations are ambiguous. So it's not one-to-one match. It's one-to-many senses or meanings. Yeah? And in an American admission notes, a bit later, and back in 2009, they found out about 15.7% of their admission notes are filled with abbreviations. And it's not just in those with native English language, but also in countries that use English as a second language, but they use it in their electronic medical notes. So for example, in the Botswana clinical notes, they found 58.1% of their medical notes have used actually medical abbreviations. So my study tried to look at the Malaysian medical notes, because in Malaysia we do use English, a mix of, I would say, UK and US spelling, but basically back in 20-30 years ago, most of our doctors are not only trained internally in Malaysia, but also we have a lot of external trainings. So most of them comes from Australia, UK, Ireland, US, Canada, and so forth. So that's why it is for us in Malaysia, we do use English in our clinical notes. So I thought it would be interesting to see what it's like to study the medical abbreviations in a country that uses English as a second language. Right? Recently, there was a study, I forgot to put a reference here. It was a recent survey actually in one of the public hospital in Malaysia that looks into on the use of medical abbreviations and how it affected the care that is being given. So from the survey, they found out that 13 to 17% had acknowledged that they had delayed in administering medications, even performing procedures and making diagnosis, while 12% of them had made a wrong diagnosis before because of wrongly interpreting medical abbreviations, and a few, even 9%, had given wrong therapies. So in a sense that I would say even in international societies that looks at the use of medical abbreviations, they look primarily at the use of medical abbreviations and its potential harm when it comes to medical prescription. So in my study, we tried to make it a bit larger outside of medical prescription and look at into clinical notes. So just to reiterate that we know that abbreviations are common and ambiguous. For my research, I want to find out how common are they and how ambiguous are they in the Malaysian electronic medical notes written in English. We know that there's potential danger to patients from previous study in a local study. And we know that since EMR, with EMR, it is much easier to share clinical notes, not just share, but also to, the copy and paste culture now that we have the electronic medical notes. So those kind of habits, we want to see that as it progresses, how does it affect patient care and patient safety, right? So for this research, it's just focused on a small aspect, that is to determine factors associated with dangerous ambiguous abbreviations. Right. So the source of my study comes from the Malaysian Health Data Warehouse. Most of the data in Malaysian Health Data Warehouse are aggregated. That means a very structured data. But there is a portion in the Malaysian Health Data Warehouse that looks into the unstructured data, which is written in text. So most of those now are discharge summaries, but there are also other clinical notes, right? So the one that for this research, we look at the discharge notes because that is the most predominant that we have in Malaysian Health Data Warehouse. And because it covers both the public and private hospitals. So in Malaysia, we have two-tier hospitals. One is privately funded and another one is publicly funded. So it's a good mix of discharge notes because it could lead us to kind of like highlight basically how do they document, does it differ from a public and private hospital? So it's common in Malaysia that public hospitals are usually written by junior doctors. That's basically their I would say their task, their responsibility. Whereas in private hospitals, we don't have junior doctors. Junior doctors basically are those who recently graduated, are doing their internship and have not really signed off as a practitioner that can practice by themselves. So in the private hospital, they don't have junior doctors. Most of the time, they have doctors who are already past their internship. So those who document in a private hospital are usually senior doctors, we call it. And our discharge summary comes from many, but predominantly from the cardiology and general medicine. So those are the data that we're dealing with and the data source. What we did was we did a manual annotation. We actually sort of hired a part-timer of medical graduates to annotate about 1,102 discharge notes. What they are tasked to do is they are supposed to find out which token or which word, usually we use the word token here, to highlight these are abbreviations, and if it is an abbreviation, then they have to give the meaning or the sense of it, right? So from that exercises, we can identify how many of those abbreviations are ambiguous, or those with more than 2 or more senses. So from that 1,102 discharge notes, there are about 180,000 over tokens. 22.6% of the tokens are abbreviations. But the ambiguous abbreviations are about 4.2% of the tokens, or I would say about 1/5 of the abbreviations. And when we look at those instances, those 7,640 instances, we can come up with 94 unique ambiguous abbreviations that is mapped to about 220 senses. Right? So you can see there's about every one ambiguous abbreviation have at least about 2 senses. So from there, we try to identify the predictors that categorize these abbreviations as dangerous. So our target is the danger level. We have 3 categories, which is benign, possibly dangerous, and dangerous. What we did was we appoint 3 medical doctors who have like more than 5 clinical experience. And for each of the ambiguous abbreviations, like the 94 ambiguous abbreviations, they would label it whether is it benign or possibly dangerous or dangerous. You see if I can have that. That's right. So how do they define it? Well, they label this independently, and after they finished it, then they adjudicate by consensus. That means if there is any difference between the doctors, the 3 doctors, then they will look back and then try to clarify what will be the correct or the most appropriate danger level for that ambiguous abbreviations. So for dangerous ones is for dangerous, where misinterpreted ambiguous abbreviations within a group of possible senses poses a clear and severe danger to patients' lives, whereas the benign is the total opposite, no danger to patients' lives, and possibly dangerous is if they think that there's non-severe implications to patients' lives. So once they did that, then we actually run our model based on the odds ratio, and this is our results. Right, so this chart shows that the total instances of ambiguous abbreviations by the number of senses. For we actually categorized the 100 series are the cardiology summaries. The 200 series is also cardiology summaries, but written by junior doctors. And the 300 series are the general medicine discharge summaries, and they're also written by junior doctors. Whereas the last column is where everything is combined. So you can see that as everything is more combined, you've got more senses. That means the abbreviations become more ambiguous. And this slide shows actually how those ambiguous abbreviations are distributed in the based on the danger level as well as the SNOMED CT type. What I can say here is it's really difficult to see any pattern that really says that which SNOMED CT type relates to the danger level, and because once we run the analysis, we find that the numbers become less and less. Our power, the power of the analysis reduced because of the number of instances also reduced. So we had to actually combine this together and only took as disorder procedure, and the rest as others as the predictor. So if I want to show you back this, the variables, we look into the number of senses as the predictor, discipline as the predictor, seniority, whether it's written by junior doctor or senior doctor, both doctors. We try to keep it as binomial as possible. And then whether the category is medication related or not, a laboratory related or not, and the SNOMED CT type. And right, so based on the danger level, more than 50% is thought to be dangerous. The ambiguous abbreviations are dangerous, and only a few, 6%, are considered benign. After we run the predictive modeling, we find that out of those 6 variables or predictor that we tested, only 4 actually give any meaning to the model, and which is the increasing number of senses. As more senses becomes, as more abbreviation has more senses, it becomes more dangerous. Abbreviations related to medication. So if the medication, if the abbreviation is related to medication, not just in terms of SNOMED CT type, but also whether it is used in prescription, the oral route, whether it is used, the name of a drug, and so forth. Anything that's related to prescription and giving medication, it falls into this category, and it does give indicate a positive indicator to say that an abbreviation is dangerous or not. And then we do find there's a positive relationship to the disorder and procedure for the SNOMED CT type. So, for example, if you want this to be, be implemented as a clinical decision support system, the system might have to be able to identify these abbreviations first, detect the abbreviations, and then label these abbreviations as the category under SNOMED CT. And if it falls under disorder and procedure, then it will give a very positive indication that it is a dangerous abbreviation. And finally, a final finding from us is that we found that those who use single abbreviations in a single discipline, in the same discharge notes, they tend to be more dangerous. And we think it's because when you are in a single discipline, you think that it won't be used by other discipline, and most probably when you use it in a multiple discipline, then you are more aware and more careful. You know that your colleagues from other discipline are reading it, so you are less use less abbreviations that are ambiguous. So, right. So based on that predictive modeling, we find that it's pretty good. The area under the curve is 0.75. And then all the other indicators such as Hosmer-Lemma show goodness of fit, AIC and BIC all shows that the 4 predictors give a pretty good indication on whether an abbreviation is dangerous or not. So part of the challenges in the study for us is actually, there's 2 actually. One is when we want to categorize according to SNOMED CT type. Remember, we know that there are 19 high-level hierarchies. We try to, at first, map this to the according 19 level hierarchies. But because our sample size is small and became smaller, it affected the power of the analysis. We had to regroup the abbreviations into disorder, procedure, and the rest as others. Secondly, we find that it's just the structure of SNOMED CT that when you want to say that an abbreviation is related to medication is a bit different, different when you use SNOMED CT type, because we know that for medication substance and laboratory substance, they are not separated. It is all under substance category. And another example is when you want to categorize an abbreviation as a procedure. A laboratory procedure and surgical procedure are combined under the procedure category. It's quite difficult for us to separate the two. So probably in future, if we have more data, we could actually have more sample size to actually label these abbreviations into a more, would say, more specific type and predict it better. So as a conclusion, from our study, we have classified and determined that there are 4 independent variables that can predict dangerous abbreviations quite accurately. One of them is using SNOMED CT as the predictor. The others are the increasing number of senses for an abbreviation, its relation to medication or prescription, and when the abbreviation is used in a single discipline. So we think that if you want to build a decision support system on top of an EMR, whether to alert doctors when they're typing in, and to alert doctors whether should they actually disambiguate these abbreviations, or even not just notify that these abbreviations are dangerous, but build on top of that a system that can actually interpret what these abbreviations are. And secondly, there are a lot of studies that shows they are auditing their clinical documentation, especially on the prescription. So what they do is they audit whether these prescriptions use medical abbreviations or not. But these are very manual in procedure. It takes a lot of effort, a whole team to just audit those prescriptions written by doctors. So if we were able to incorporate this automatic decision support system to identify abbreviations that not just being used in prescription, those are related to medication, it can actually help all this auditing to improve the clinical documentation and even perhaps improve the safety of for the patients. So I think in future, if we have more samples and more data, SNOMED CT and the hierarchy can play a role when it comes to predicting the danger of medical abbreviations and maybe other things as well. So with that, I conclude my presentation.
Thanks, Ismat. That was really, really interesting. And I think a really new way of talking about how SNOMED CT is used from clinical practice through to data analysis, predictive analytics, and where you can go from here. So thank you so much for bringing your work and sharing it with us. Now to the questions. If you'll give us a moment, we're just going to move over from our pre-recorded content to interact with you live. And this will be so that Ismat can look at all the questions that have been coming in during the presentation and we can get to answering some of those. One thing I do want to note is that this session will be made available on the platform for 3 months after the conference. So feel free to come back and revisit it and learn more from it as well. And with that, we'll move over to the questions. Thanks.
Okay.
Hello, everybody. Yes, we're now live, and thanks, Ismat. Can I just remind you to use the live Q&A button in your AirTouch device to type in your questions. So yeah, we've got a few questions that have come in, so I'll just go on to those, Ismat. I've got a question from Mark. Did you consider the number of abbreviations that can be disambiguated simply by reading the words preceding or following the abbreviation?
Well, that's a good question because it's actually the next part of my research, which is almost completed. Part of the next work is actually about disambiguating those abbreviations based on word embeddings, which looks into the context of the words before and after. So, yep, that's exactly what we're going to do.
Oh, that's interesting. Thank you. And another question from Iqbal. How about words with typographical errors that end up into another word that has a different meaning? Simple example, beard and bread. It is an entirely different ballgame, but do you think the same concept method from your research can be replicated and applied?
Well, actually, my research only focused on abbreviations, and I have been talking to people that looks into misspellings. So there are techniques to address that. So usually before, if you put it in a whole solution, usually what they need to do is to address those misspellings first, those typographical errors, before they can address other things like abbreviations and so on. So at the moment, in this context, I don't address it, but there are techniques to do that.
Okay, thank you. And just from my perspective, when I was listening to the presentation, and it was really interesting to see how you defined the danger levels. And I just wondered, what did the doctors think who were actually reviewing the abbreviations? You know, did they make any comments? Were they surprised?
I guess when we did the labeling, actually we invited 3 doctors. It's kind of funny because they were not that surprised, but at the same time, it's like, what can we do about it? You know, I mean, and they know that it's dangerous, but it's as if it's like this habit and this culture of, you know, I accept it. I think you know what I mean. So they know it's dangerous, but they kind of like not really understand how dangerous it is. So when we show that kind of that chart, and it says that, okay, imagine if you actually ordered this, but because you make a mistake, you actually had to take another blood sample again. That's basically harming the patient, because you're not supposed to do that procedure because you made a mistake.
Absolutely. Okay, so another question, one from Susie. You mentioned your doctors utilize English in various dialects, US, Australian, UK, etc. Do you know if there are differences in medical abbreviations between these different English languages? As you focused on abbreviations, I'm guessing you didn't have to do any reconcile between the different language rep set files.
Actually, that's a very good question. But when we look at the notes, it's like jumbled up already. We don't know whether this is written by a graduate from UK or a graduate from US or graduate from Australia or even Malaysia. So, and even if their teachers are graduated from all these English-speaking countries. So right now we only see what we have. But I think my previous project with trying to map the cardiology data set, we find there are, of course, words like fast atrial fibrillation and rapid atrial fibrillation. So those kind of things, rapid AF, RAF, fast AF, FAF. I think I'm sure it happens. But I've never actually tried to categorize where these abbreviations come from which region.
Yeah, it's just an interesting comment as well from Marie Alexandra, that she's saying you're doing a great job with the presentation, and it's often an item for hospital accreditation to forbid the abbreviation use.
That's true.
So that's an interesting perspective as well. I'm afraid we're pretty much out of time now. So thank you for answering the questions, and thank you everybody for submitting some really interesting questions. If anyone has any additional questions, I just encourage you to connect via the meeting hub. But thanks for joining us, and enjoy the rest of the expo.